Well, good morning, everyone. Thank you very much for coming today. We're going to go ahead and get started because, as you see, we have a packed schedule. And one of my jobs today is to keep everybody on time, so I figure I ought to at least get a good start at that. My name is Rich D'Aquila, and I'm really so excited and pleased that we're all here today. I want to start by making sure everyone has picked up two things when you walked in by the elevators. And I'll tell you about the folded handout in a moment. But first, just a few logistical housekeeping things. The bathrooms are on that side of this auditorium. You can get to them from either door. And there's another set of bathrooms out towards the elevator. There's a coat rack to my left. We will be having breaks a short walk away. When you go out to where the elevators are, if you take a left, you'll see a lot of tables set up. That's where all the breaks and lunch will be. There is Wi-Fi that's open in this room. It's NMH guest. Feel free to use that. And on the topic of what we're about today, this is very much intended to be a scientific workshop. And what that means to me is a free and open exchange of all of the latest information that's available. So I've encouraged all the speakers to share unpublished data. And we are going to be videotaping this session for archiving on the web. However, I want to reassure all of the speakers and let other people know that there will be some slides that will get edited out of what appears on the web, because we want to make sure that speakers don't jeopardize their ability to publish their work. And in the same vein, I expect there will be some reporters attending the event today, and I'd ask that reporters please speak directly to speakers if they have any questions. And for everybody, please don't photograph any of the slides. And a big part of this being successful is having a lot of questions and answers. And I want them to be as in-depth as people need them to be or want them to be. But also, if people are new to this area and have questions, you should not feel at all hesitant to ask. There's no such thing as a dumb question. So please feel free. The microphones are in that back row. I would ask, and I'll keep reminding you, when you come up to ask a question, please tell us who you are and your institution. Okay, so I would like to have the first set of slides put up, my slides. And I want to start by saying this is a very important part of 2 days of events. A group of us have invited Timothy Ray Brown, the first person cured of HIV, to visit Chicago to celebrate the 7th anniversary of his being off of antiretrovirals and free of HIV. And last night we had a community forum, and here's a sign to my right from that community forum where Timothy told his story. I gave an overview of cure research in lay terms, and we also had a patient advocate from the Core Center describe his experience living with HIV for more than 20 years. It was really quite moving, and it will also be on the web in the near future. You can look for that and this at aids.northwestern.edu, but don't go there now. It's still under construction. Give us a week or two. And then here's the schedule for today. And I want to start by saying welcome to all of the people who made this possible, and most especially to Timothy Ray Brown and his foundation, and our planning committee. The planning committee included many people who organized both the community forum last night and helped in organizing this, although the symposium today was really the hard work of myself and Dr. Brian Mustansky from the Impact Program for LGBT Health and Development at Northwestern. And you'll hear more about the Impact Program from Brian himself later. But the planning committee organizations deserve a lot of thanks. The Chicago Department of Public Health in particular did a fabulous job. The AIDS Foundation of Chicago was the host for last evening's event, and the University of Chicago, the Center on Halsted, Howard Brown, Vita Sita, Chicago House, Brothers Health Collective, TPAN, UIC, and Loyola all had major roles in making this happen. And Timothy, I don't want to put you on the spot, but I said thank you to you before, so I'll say thank you to you again for being here.
Thank you for having me.
So what I'm going to try to do in the next 15 minutes or so is give a brief survey of HIV cure research, and I'm going to go very fast, but a lot of these topics are going to be covered by other speakers in more depth. And please do, if you have questions, write them down, save the questions for after our second speaker, when we'll have questions both about cure research and about the epidemiology of HIV in Chicago. So this is sort of the outline of everything I'm going to cover. And you know, the first attempt to cure HIV was the idea that now we have drugs and we can use them. Unfortunately, that didn't really work, and there are now many more strategies for a cure that are being studied. But I think it's very important to emphasize that none of this would have happened without Mr. Brown. That even as recently as 5 years ago, it was impossible to use the word cure and the term HIV in the same sentence. It was considered impossible. It just couldn't happen. But as a result of some out-of-the-box thinking and real courage on Mr. Brown's part, we now know that it can happen. So the strategies being worked on are similar to what happened for him, an allogeneic stem cell transplant. There's also work going on autologous stem cell transplants, the shock and kill method, starting art very early. And during this symposium today, we'll talk about a number of other topics which I think are not yet well studied, but where we might profitably go in the future. See if I can get this to move. Okay. So the hit hard, hit early was popularized by David Ho and Alan Perlson after the introduction of HAART in '96. And their mathematical modeling predicted that there were two phases of decay of HIV, that the infected T cells decayed rapidly and infected macrophages decayed more slowly. But if you put together the two slopes of decay, one that was steep, the other that was more shallow, they estimated that it would only take a few years after HAART was started for all of the cells that were infected before HAART to die. And if HAART was really fully effective, as we thought it was, well, then the minute it started, there shouldn't be any new cells being infected, and all the cells that were already infected should die off, and then people should be able to stop their medicines. Well, unfortunately, Bob Silicano at Hopkins and many others identified a third phase of decay, and that phase is essentially flat. So after viral load in the blood goes down to undetectable levels, if we use more sensitive assays, we could see that there's still some viremia there, and it does not go down any further. It stays flat for life because the virus is in resting memory T cells that persist for life. And it's only 1 in a million of them that have copies of HIV that are quiescent, that are not replicating. But those cells persist and they don't die, and if HAART is stopped and those cells meet an antigen, they reactivate virus replication, and then the virus can start to spread, basically reinitiating what happens at the very beginning of infection. And like clockwork, viremia rebounds between 2 and 3 weeks after people stop HAART, when HAART is started in the customary way, which is many months or years after infection. And from now on, I'm not going to use the term HAART because I don't think it's active enough, so we should stop calling it highly active. So I'll just call it ART. And the other concept that we need to understand is functional cure versus eradication. Functional cure means we can still find some cells that harbor latent HIV genomes, but those cells aren't able to rekindle a full-blown infection. Maybe those viruses are replication incompetent, but for whatever reason, there's still a trace of HIV, but no evidence of HIV being able to replicate in the body. And we don't really know how the latent reservoir in resting memory cells is established. This is the dogma from Bob Silicano, that when a cell is activated, that's when it replicates HIV, a T cell, I should say, an effector T cell. And then after it gets activated, while HIV is starting to replicate, it cycles back to rest. And it does that within a day after the infection starts and before a day and a half to 2 days when the infection will have killed that cell. And when it goes back to rest, virus replication turns off, the virus stays integrated in the chromosome as a provirus, and it can persist for life and potentially be reactivated. Now, that's the model on top for how we generate memory T cells that provide long-lasting memory to any antigen that we've seen. But there's increasing support for an alternate model that's on the bottom here, where it's possible for naive T cells or T stem cell memory cells to do what's called homeostatic proliferation and regenerate themselves. And it is possible that those cells could be directly infected by HIV. In other words, HIV may not need to infect an activated cell. It may be able to infect a cell that is completely at rest. So that would have very different implications for how we approach this problem. But the biology of that is really still uncertain. And the other approach that's been tried is to just add more drugs, because obviously the drugs work. If they're not working well enough, we'll just put more on board and inhibit virus replication more. But in most studies, this did not decrease the low level of viremia that persists or the number of cells that contain integrated provirus. And so the consensus is now that this reservoir is not maintained by new rounds of replication, that the latent viruses are maintained because the cells that contain them homeostatically proliferate. They divide, and when they divide, the integrated HIV that's in them also gets divided and persists. One of those two daughter cells may die, but the other one will persist, and months later, it too will divide, and so it passes along the latent HIV. However, as in everything in this field, there's controversy. Recent studies show that there may be some evidence that intensifying therapy, at least in some patients, may decrease the reservoir. And I put some citations there. There's also questions about whether with advancing HIV disease, lymph nodes can be fibrotic, and that can limit the ability of ART, of the drugs, to access all of the cells in the lymph nodes, and maybe that is another reason why the drugs are ineffective. So what we believe now is on the top, and again, this is from Bob Silicano, where we think the flat line here with all this dark-colored persistent virus is maintained by the cells. I'm sorry, I said that wrong. The top is the model of where there would be ongoing replication, where new viruses are made and infect new cells, which cycle back to rest, and the reservoir is replenished by new rounds of replication. But the alternative is that the replication in the dark color actually ends, but the cells persist just because they divide. And the consensus now is on the bottom model, but again, the data are not completely all in agreement. And we had some interest in understanding why some 1% of infected people have control of replication. These are what are called elite controllers who maintain very low viremia without needing any antiretroviral drugs. And they have a smaller latent reservoir. Reactivation is less frequent from that reservoir. And the thought was that's because they have better immunity than the average person. So there were efforts to generate better immunity in non-controllers who lacked the favorable HLA alleles that seem to be really critical for the good immunity in the elite controllers. And the idea was that if we could treat very early, that would prevent loss of HIV-specific CD4 positive T cells that orchestrate the immune response. And that would then allow other aspects of immunity to stay strong, including CD8, CTL activity. So there were attempts in the 90s to start ART very early, and then the idea was to stop the medicines to allow a little bit of virus to re-express so that the immune system would see some antigens, and that would trigger better CTL immunity, better CD8 immunity. And it looked like this might work, but it really only had short-lived benefit, and as more studies were done, by the early 2000s, we learned that this did not boost immunity. There was a study in very advanced patients called the SMART study. Again, a very different population than treating very early. But the SMART study basically killed any enthusiasm for structured treatment interruptions because the people who had interruptions in their treatment actually did much worse. They had many more inflammatory consequences, things like cardiovascular disease. So this is what set us on the stage. The first success was Mr. Brown, who proves the concept that after getting CCR5 negative donor marrow that could not be infected, he has been off of antiretrovirals for 7 years now. And that citation is the report that was in the New England Journal about him, and you'll hear more from him after lunch about his story. This was attempted to be repeated without using the CCR5 negative donor cells, and Tim Henrich from Harvard will tell us about his experience treating those two patients. Unfortunately, although they could not find any evidence of latent virus in the laboratory while these two patients were still on antiretrovirals after their allogeneic marrow transplant, once the antiretrovirals came off, they did relapse within a few months, and you'll hear a lot more from Tim about that. So this led a lot of people, including me, to think that these relapses suggest that it's really important to have CCR5 negative cells as part of what worked in Mr. Brown's case. Of course, there are other factors that could have helped. The conditioning regimen, that means getting rid of all the HIV-infected cells that were his own cells, and maybe graft versus host disease helped to eliminate some of the HIV-infected cells that survived the conditioning. Mr. Brown also had CCR5 heterozygosity himself, and so maybe that's a benefit. There's some recent data that suggests that maybe that does help. And then, of course, the big question about this approach is how feasible is this on a larger scale? Can we really do it for people who don't need a transplant for cancer, which is now the only indication for doing this because it's a highly morbid, very difficult procedure. So one way around that is to take a patient's own cells, disrupt the CCR5, and there was a recent report in the New England Journal describing an attempt to do this using peripheral mature T cells, not stem cells, and it looked like there was some success. So this is an area where there will be further research, and Dr. Henrich will talk a little bit more about this during his talk this afternoon. The biggest emphasis in cure research in the past 3 or 4 years, since it really got off the ground after Mr. Brown's success, has been an approach nicknamed shock and kill. Initially, people tried to use antibodies or mitogens to activate all T cells, but that causes way too much toxicity, and generalized immune activation just makes that an impossible approach. So people have been investigating ways to reactivate provirus without causing generalized immune activation, without making the cells proliferate, and histone deacetylase inhibitors have been tried. They look like they may increase cellular HIV RNA expression, but unfortunately the cells that re-express HIV, where it used to be silent, they don't die. And so there's efforts now to figure out a way to do some sort of therapeutic vaccination that would allow the body to target the cells that have reactivated HIV and kill them, because the virus itself doesn't seem to do that. And we really don't know yet if we get viruses produced this way. All we know is that you get RNA made. We don't know if there actually are infectious viruses made. And there were 2 studies that came out within the past month that suggest that the agents that are now under investigation really don't work very well, at least in the laboratory under the conditions that they tried. And both of these different groups, Bob Silicano's group and John Meller's group, concluded that we're going to need combinations of what are called latency reversing agents, or LRAs. And that's not really been studied yet. So that's another sort of drawback to all this. And right now, we don't have any information about how many side effects there would be from repeatedly giving these latency reversing agents. They've only been used for limited durations, but they do activate all kinds of cellular genes, not just HIV proviruses. So the worry is that even though they don't make cells proliferate, they may lead to other side effects, including possibly a risk of malignancy. So I think the most promising area is what's called post-treatment control. This is inducing a sustained remission after stopping ART that was started very early during what's called the restorative window. And this leads to a phenotype like spontaneous elite controllers, but we can get this in people who don't have those favorable HLA types that the elite controllers have. And you'll hear from Dr. Sayez Sirian about his study, the Visconti study, where about 15%, that's an estimate, of early ART starts will lead to the ability of stopping the drugs after a couple years and maintaining viral control. And Dr. Prasad will talk to us about the Mississippi Baby, where therapy was also started early and led to a sustained remission. And we know from studies in Thailand that starting ART this early really decreases the amount of provirus in resting memory cells, and we think that's critical to how this works. But there's also a couple studies from the New England Journal in January of 2013 that showed in the first 4 to 6 months after infection, the body can fight back. There are strong defenses that lead to an increase in CD4 count spontaneously after the early drop, and then it's only after about that 6-month time frame when CD4 count starts going down again. So I think we need more work to understand what defense is lost in those first few months of virus replication, and how can we preserve that or replete it and restore it if someone starts therapy later. So this is a slide that Bob Silicano generously shared with me, because the field is now moving towards the idea that whether early therapy by itself is going to lead to some proportion of people being cured or not, it's probably a good strategy to incorporate into other efforts. So what he's proposing is that we try to start therapy as early as we can to limit that latent reservoir, which will make any strategy for cure a little bit easier, which might include doing therapeutic vaccination while people are still on ART, and then maybe giving them latency reversing agents and hoping that this period of remission lasts a lifetime and not just months or years. So thank you for your attention. And we're going to change the pace now, and please hold your questions for after the next speaker. And I'm going to ask Nick Prachand from the Chicago Department of Public Health to come up and give us an overview of HIV epidemiology in Chicago. Nick is the Director of Epidemiology and Surveillance for the Department of Public Health, and we're thrilled to have you here, Nick.
Great, thanks, Rich. Do we have a clicker? Good. I just want to thank Rich for organizing this and kind of just inspiring this movement in Chicago, and Timothy for making this possible. It was great meeting you last night, great event. I want to acknowledge my colleagues from the Health Department, Nanette Benbow, the Deputy Commissioner, I believe she's here, and there she is, and Corey Bloom, one of our medical directors in HIV STI division. So we're going to give some context to a lot of this. This is not related to cure research. This is more talking about the situation where we are with the virus in the city of Chicago specifically. So, but I think it'll provide an important context to all of the sort of, to present sort of the burden and the challenges that we face in seeking cure or, widespread viral suppression. So most of the data that you see is coming out of two publications. One is, on the left is a surveillance report that we released in December 2013. And then on the right, we have a special report coming out in May of 2014, next month, that looks at the continuum of care indicators, which we will talk about. So these are all available on the City of Chicago's Health Department's website. So we're just going to dig right into it. We're going to get deep into the surveillance data. We're looking at 20 years of trends in HIV and AIDS diagnoses here. The blue line is indicative of HIV diagnosis, the red line being AIDS diagnosis. So we've seen almost a 50% decline in AIDS, HIV and AIDS diagnoses over the last 10 years since the beginning of the decade. In 2000, we were seeing about 1,900 cases a year, 1,900 diagnoses a year. Now we're down to just over 1,000 in our last year of report, which is 2011. So all the data reflected will be through 2011. There's typically a lag in surveillance and reporting. We usually wait 18 months after the end of the year to synthesize and release our data. So that being said, the 2012 data should be coming out shortly, probably this summer. So large reductions over time, both in HIV and AIDS diagnoses. And then we see sort of in yellow the number of deaths due to HIV disease at about 400 in the last year of data availability. And that's remained, sort of plateaued over the last 5 or 6 years. Really not much progress in that. The green line is an important indicator. It's something we call concurrent infection. So these are people who are diagnosed with AIDS within 12 months of their initial HIV diagnoses. So around the year 2000, about a third or more of HIV diagnoses were diagnosed with AIDS within a year of their diagnoses. We're down to now about 25%. So we've made some decent progress in sort of addressing the issue of late testing. So we're going to look at some maps of the city of Chicago. This is a map of the city by the 77 community areas, which is how we often frequently divide our city up into sort of neighborhoods. So this is looking at the number of people living with HIV, so the prevalence of HIV diagnoses throughout the city. So you see in the sort of the northeast corridor here, the Uptown, Rogers Park, Boys Town neighborhoods, where we see the highest number of people living with HIV. So in these communities, we have about 1,200 people or so living in each of those 3 community areas. You also see 2 other clusters of concentrated people living with HIV on the sort of central and near south side, as well as the far west side of the city. In those areas, we see usually between like 300 or 400 people living with HIV in those community areas, so to just give you a magnitude of what constitutes high prevalence. Overall, the city prevalence is just under 0.8%, which is, I think is interesting, is the global prevalence of HIV is also 0.8%. And the communities with the highest HIV prevalence rates in the city are the Uptown and Edgewater neighborhoods. They're at about 2.5%. And then outside of that context, the South Shore neighborhood has about 1.4% prevalence, which is the highest prevalence outside of the sort of Boys Town context. So we know that there's about 21,555 people living with HIV that have been reported to the health department. We also estimate that about 16% of people living with HIV don't know their HIV status. So we estimate that there are probably about 4,000 people undiagnosed with HIV living in the city of Chicago. So just looking at some numbers across different kinds of groups, about 11,000 African Americans, close to 4,000 Hispanics, and about 5,500 whites living with HIV. So these are the prevalence rates within these groups. So 1.3% prevalence among African Americans living in Chicago. So that's, sort of, if you look at it in a global context, that's sort of getting close to the equivalent of the general adult prevalence in areas of the globe like the Caribbean, like Haiti and Jamaica. Much lower rates of prevalence among Hispanics and whites. 17,000 males living with HIV in the city of Chicago, almost 13,000 MSM, close to 5,000 IDU, and close to 4,000 heterosexuals. When we look at youth, we see about 1,100 people under the age of 25 living with HIV, and all told about 2,500 under the age of 30 living with HIV. So this is a map of diagnoses. So we're seeing about 1,000 diagnoses a year in the city of Chicago. So our diagnosis rate is about 37.4 for the city itself. When you open it up to the entire MSA, so including collar counties, our MSA diagnosis rate is about 24 per 100,000. So how does that compare nationally? So in Washington D.C. we know there's a diagnosis rate of about 177 per 100,000, and then that we sort of exist between Washington D.C. and Provo, Utah, which is the MSA with the lowest prevalence rate of about 8 per million. So that out of 100 MSAs, we sort of fall in between. So, we're lower than places like Miami, which has about 60 per 100,000, or New Orleans, which is about 50 per 100,000. So we're closer to places like Atlanta, Detroit, Los Angeles, in terms of our MSA prevalence. So when we look at diagnosis rates, we see, again, similar pattern in sort of how they cluster, the highest diagnosis rates being in the Northeast corridor again, largely MSM diagnoses, as well as this sort of central near South Side cluster, where we're seeing about 25% of infections just in these 7 community areas in the darkest colors. And then a cluster here on the far west side, which include areas like Austin, East and West Garfield Park, Humboldt Park, and North Lawndale. So the community areas with the highest diagnosis rates, again, are the Edgewater and Uptown neighborhoods, which have a diagnosis rate of over 1 in 1,000 persons being diagnosed annually with HIV. The only other community area in the city that has higher than a 1 in 1,000 diagnosis rate would be Washington Park here, which is number 40 in the central south of the city. So that's how our diagnosis rates look. So let's sort of focus on diagnoses, the characteristics. So we know that the vast majority of cases, new diagnoses, are among males, 80%. About a third of new diagnoses being among 20 to 29-year-olds. And that's been a major sort of shift in what age group dominates the epidemic. If you look at, this is a trend looking at diagnoses by age. So the red line being 13 to 19-year-olds, and the green line being 20 to 29-year-olds. So you see that around 2006, you see that 20 to 29-year-olds sort of took over the number one spot in number of diagnoses compared to what's traditionally been the dominant group, the 30 to 50-year-old. So when you look at sort of this age group, this age distribution over time, it's not so much that the 20 to 29-year-olds are increasing in diagnoses, but more that it's offset by the decrease in older ages. So we've seen sort of a plateau, but nonetheless, 20 to 29-year-olds now are the most dominant group. If we do dig into that group, the 20 to 24-year-olds are actually the only demographic group in the city of Chicago that's experiencing any increase in new diagnoses. So overall, about 40% of new infections among people less than 30 years old. So this is definitely a huge shift in the makeup of the epidemic. When we look at the racial distribution, over half of cases are among non-Hispanic blacks, compared to about 1 in 5 among Hispanics, about 1 in 6 among whites, and about 1 in 10 in other groups. And that sort of brings out the other big story in HIV, which is racial disparity. So this is looking at diagnoses by race ethnicity over time, looking at blacks in blue, whites in red, Hispanics in green, and other ethnicities in purple. Seeing the the disparity kind of shrinking over the course of the decade, but still diagnosis rates triple among Black Chicagoans compared to 2.5 times that of Latinos and more than triple that of whites. So the story, in terms of racial disparity, what we've seen, some good news are that the recent decreases among Black women. So just in the last 5 years, we've seen about a 35% decrease among diagnoses among Black women, and this is mirrors sort of national trends. Still, the fact that there's been a decrease in that group still leaves a huge disparity, and this is sort of the largest disparity in the entire local epidemic. The disparity between Black and white females, even though, despite how this graph looks, has actually grown. We're about 10 to 1 in 2000, and we're about 13 to 1 in 2011. In 2011, there were only 10 white women diagnosed with HIV in the city of Chicago. So when we look at MSM, MSM is the group that's predominant in the diagnoses of HIV in the city of Chicago. This hasn't always been the case. We're actually at a time where MSM are dominating the epidemic like they never have before in terms of numbers. We're almost at 70% of new diagnoses being among MSM. Just 5 years ago, it was about 60%, and just at the beginning of the decade, it was actually less than half of the epidemic was among MSM. So that's something that sort of a context, and that's really related to the shifts in the other risk groups. So among IDUs, we've seen a 90% decrease in new diagnoses across the decade, so almost 500 diagnoses in the year 2000, and now just over 50 diagnoses a year in 2011. So, people always want to know what's behind this decrease. To me, this is such an important part of describing what the potential of addressing this epidemic. What's really behind this? The structural factors related to the universal accessibility of syringes through needle exchange programs in the city. But sort of concomitant with that is the real sort of really palpable change in the social norms and stigma among IDUs in terms of, is it okay to share a needle with somebody? And the answer really is no, unless it's a very intimate partner. There's virtually no sharing. It's almost like sharing a drink of water or your utensil with a stranger at a meal. Sort of the social normalization of that sort of behavior has really been, in my opinion, sort of the crux of this reduction. And so when people say there's nothing to learn from the IDU population, I would challenge that. So 50% decrease among heterosexuals. Also, so close to 400 diagnoses in the year 2000, down to just over 200 today. This is largely, I think, driven, again, by the decrease in Black females and sort of just, I think, the on-the-ground work that the prevention community has put forth in addressing HIV, but still, obviously, a long way to go. Much more marginal decreases when we look at MSM, so 15% decrease across the decade, so some progress, but really, when you look at the last 5 years, there's been absolutely no decrease, no change in the amount of diagnoses in MSM in the city of Chicago. And the story really can be more clear through the racial sort of lens, where we see in around 2005, you see this really dramatic bifurcation in rates between Black MSM and white MSM. So the offset of white MSM starting this very steep decline in around 2005, really sort of being offset by sort of no decrease among Black MSM. So seeing almost 350 diagnoses among Black MSM compared to less than 150 diagnoses among Latino or white MSM in the city of Chicago. And in fact, it's the first year that Hispanics have superseded white MSM in number of diagnoses. When we look at MSM by age group overall, so here's where we see the first sign of this ever elusive increase. So here in the 20 to 29-year-old group in green, we do see this increase in diagnoses over the last 5 years, starting in 2007, and then just really sort of, again, highlighting this decrease among the 30 to 39-year-old and 40 to 49-year-olds over the same time period. Also, it's important to look at the red line, which is the 13 to 19-year-olds, and we've seen a pretty dramatic decrease, almost from 0 cases at 2000 to almost 50 cases in 2011. When we look at white MSM, we see the pattern. This is white MSM by age, so we see this really steep decline in the 30 to 50-year-olds, represented by the purple and yellow lines. So pretty dramatic. This is the group that's dominated the MSM epidemic in Chicago and nationally since the beginning of the epidemic. And so now the story has changed considerably. When we look at Latino MSM, our numbers get small, so the lines get a little jaggly as we sort of break it down by year, by age group. But we are seeing that among Latino MSM, the 20 to 29-year-olds are also exhibiting a recent increase in number of diagnoses and sort of generally downward trend continuing in the 30 to 50-year-olds. And then black MSM is almost a completely different story. There is a similarity in terms of the steep decline in the 30 to 39-year-old and as well as the 40 to 49-year-olds in the last 5 years. But really, 2/3 of diagnoses now being among black MSM less than 30 years old. So you see the dramatic increase in the 20 to 29-year-olds among black MSM going from just about 70 cases in 2000 up to now almost 130 cases, 150 cases a year in 2011. And then the 13 to 19-year-olds really sort of a dramatic increase of over four times increase over the decade. So the emerging pattern is for the first time, we're seeing more black MSM diagnoses than both Latino and white MSM combined. First time we're seeing this sort of pattern emerge, but this is sort of the pattern that we are now focused on as we, prioritize prevention and care in the city. So before we go on, we want to show the health department also monitors risk behaviors as part of its surveillance system. So as part of the National HIV Behavioral Surveillance System, we're able to monitor prevalence in the 3 main groups affected by HIV, meaning MSM, IDU, and heterosexuals, as well as risk drug and sex behaviors, and as well as prevention utilization. So just a couple quick slides on behaviors. So when we do these surveys annually, population-based surveys, systematic samples of MSM, IDU, and heterosexuals across the city. So we see a 28.9% prevalence rate, HIV prevalence among MSM that we surveyed in the 2011, which was our last survey year. 5.5% positivity among IDUs, and 1.7% positivity among heterosexuals. So what is a at-risk heterosexual? Essentially, CDC defines an at-risk heterosexual as a heterosexual who lives in a neighborhood with a poverty rate of greater than 30% household poverty. So these are the sort of prevalence numbers we use to describe the in-group prevalence among at-risk populations. When you look at condomless sex, you see condomless sex being sort of the norm among IDUs and heterosexuals. About a little over 10% of MSM engaging in condomless vaginal sex as well. When we look at condomless anal sex, we see that over half of MSM 2011 engaging in condomless anal sex. So still sort of a predominant behavior, as well as high levels of anal sex among IDUs and heterosexuals as well. When we look at needle sharing, about 24% of IDUs report sharing needles. So again, this is almost exclusively sharing among intimate partners. There's almost no sharing among casual partners or strangers. And 51%, so still people sharing their cookers, cotton, their rinse water. When we look at prevention utilization, we see that low rates of participation among all groups in behavioral interventions. We see differing rates in access to free condoms, MSM and IDU having much higher rates than heterosexuals. And then regular testing, so MSM, about 70% of MSM reporting having a regular HIV test, which is annually, compared to much less than half among IDUs and heterosexuals. So quickly, I'm going to finish with the continuum of care, which is, the important new measure that we're using to follow people as they get into care and move them through viral suppression, which, is our sort of current ultimate goal. We measure the continuum of care indicators through a case surveillance system. We get all CD4 and viral load reports from everybody who is HIV positive and ongoing through their care. So that's the way we sort of establish their participation in care. And we also use a behavioral survey called the Medical Monitoring Project to measure behaviors of people HIV positive persons who are enrolled in medical care. So we use this to make a weighted sample of estimates of people in care in the city of Chicago. So it involves a survey and medical record abstraction, and we use that project to come up with our retention and care, ART status, and viral load. So we look at the continuum of care a little bit differently than maybe you've seen it before. You usually see a cascade. So we separate it into linkage to care, retention and care, and then ART and viral suppression. So overall, among the 1,000 cases diagnosed in 2010, we see that almost 80% of them were linked to care within 90 days of their initial diagnoses. Of people who are living with HIV in the year 2010, 19,000, about 61% of them are indicative of being in HIV medical care. So this is our largest gap in engagement in the continuum. And then when we look at this group that is in care, we see high rates of being on ART as well as high rates of those on ART being virally suppressed among people in care. So we use this to really sort of identify and prioritize the gaps in engagement through the continuum. So just looking at some differences by subgroup, we use the Delta method to just look at standard errors and look for significant differences by subgroup. So you can see here, this is by males and females. So females being less likely to be retained in care or virally suppressed than males. When we look at by race ethnicity, we see African Americans less likely to be linked to care, less likely to be linked in care, less likely to be virally suppressed, while we see Hispanics being less likely to be retained in care. So 51% of Latinos being retained in care. Once they are retained in care, however, they have very high rates of viral suppression. So it's an interesting pattern. When we look at the continuum of care by age, we see it's all about the youth. So we see deficits among 18 to 29-year-olds in terms of being retained in care and being put on ART as well as viral suppression. So the rates among youth much lower than those among older age groups. And then when we look at MSM, this is the only risk group we can really look at because of small numbers in the other groups when we start breaking it down. We see that among MSM, we see black MSM marginally significantly different in linkage to care. And then we see Hispanic MSM as being seeing a strong deficit in retention in care. And then among African American MSM, again, less likely to be virally suppressed than Hispanic or white MSM. So across this continuum, we see, what I see here is the sort of the multiple challenges in working with all different groups, with all different cultural and social and sort of structural factors in moving people through this continuum to viral suppression. So a lot of work to do on that account. What the surveillance system doesn't account for yet are cure. We love to think about how to incorporate cure indicators into our surveillance data. But just a quick look at Chicago versus New York City and national continuum of care indicators. So this is the cascade sort of as you're more used to probably seeing it. And this is, you see it this way because many times it's calculated off people estimated to be living with care. So it's not necessarily based on hard data, but you see in Chicago about the same amount of linkage to care compared to national, but a little bit lower than New York City. We see that Chicago doing well compared to the national data on retention in care, much better than national numbers on ART, and then compared to 25% nationally, we have about 42% of our HIV positive population virally suppressed. So that's all for that, and we have happy to take questions, and you can also contact us at the health department. So thanks.
Thank you, Nick. I'd like to introduce Dr. Frank Palella from the Infectious Diseases Division of the Department of Medicine at Northwestern, who's going to moderate some Q&A. And Maybe, why don't we,
Thank you,
let Frank
Rich.
take them on?
Wow, we've heard two extremely informative but divergent in terms of their content presentations. One regarding the challenge from a viral replicative and senescence point of view of contemplating the issue of cure, and the other regarding the state of the epidemic locally. Do we have any questions first?
Come up and use the microphones, please.
Please.
Introduce yourself.
John Peller, AIDS Foundation of Chicago. Nick, I am thrilled to see that CDPH is using the term condomless sex instead of unprotected. And just really strongly encourage all of us to think more about not using the word unprotected, because there are so many different forms of protection that people are using now. So thank you for doing that, and thank you for the great data.
I think in that regard, our upcoming in our upcoming behavioral survey, which will be conducted this summer among MSM, we will be adapting a lot of local questions to looking at issues like seroadaptivity and sort of partner selection as ways of protecting oneself. So we really look forward to not just using the word condomless sex, but really understanding those other ways that people are using to protect themselves.
Thank you. You know, for our most important national meeting was held about 6 weeks ago in Boston. It's the Conference on Retroviruses and Opportunistic Infection. And one of the most heavily touted of the presentations had to do with rates of transmission among serodiscordant couples, both heterosexual and same-sex couples. The good information was that among these couples in which the infected partner was suppressed, there were no transmissions, regardless of the sexual acts. The danger in that information is that it, to some people, sends a message that that the whole issue of condomless versus unprotected sex is something that is acceptable, and I think we need to hone that message a little bit. And it has everything to do with the fact that treatment is prevention, that when you get people undetectable, they are essentially disenabled from transmitting sexually, and that's true. But we don't want that to modify the message regarding the need for protection for HIV and others. The other information that you just commented upon, New York City at CROI presented data from 2011 to 2013 talking about retention in care, and the retention in care is staggered. It's simply gone nowhere. The only thing that's improved in New York in the last 2 years is the increased number of persons that are virally suppressed. Nothing else has improved. And I think that's interesting data to juxtapose to ours. Other questions, Rob?
Is there any attempt by the city to look at acute hepatitis C in these new cases, or even the prevalence of hepatitis C?
Among HIV positive individuals? I don't. So, we historically have struggled with hepatitis C surveillance, like many jurisdictions around the country. So, we would love to be able to do it through matching through databases. We could look at hepatitis C and HIV, but we don't have particular data from our HIV surveillance system that looks at hepatitis C positivity. I think, we as part of our behavioral surveillance projects, we do hepatitis testing among MSM, IDU, and heterosexual populations, so once a year. But that will give us a sense of sort of the the co-epidemics that are occurring.
There wasn't really any urgency before, but now with all the new direct-acting antivirals that have over 90-95% success rates, I think it's really sort of changed the game. We want to be ahead of the game.
I think it's an important phenomenon that needs more clarity. Thanks.
Right. Good. Other questions? Oh, yes. For Dr. Prachand or for Dr. D'Aquila?
Luis Montaner from the Wistar Institute in Philadelphia. How much of your data between the different groups or the different ethnicities can relate to access to care? because, you know, medical care, because you spoke in the first half about prevention or sharing of needles, and only later you talked about retention once they got into the pipeline. But how much do you think relates to just access to overall care, meaning that because the difference between opening more clinics locally versus putting more money in prevention?
So I think it's a great question. I can answer part of it, and I can maybe have our deputy commissioner address that issue. But we are just starting to look at our continuum of care data, and we're starting to look at geographic sort of patterns in populations that are not retained in care. So we are mapping those against where primary care clinics are available, as well as where testing facilities are. So we are looking at that relationship. There has been some data from Philadelphia to suggest that retention in care is related to sort of geographic isolation amongst the city, so distance to primary care provider sites. So that's something that we're excited to do. We're just sort of really getting our teeth into this data now that we have sort of, finally we have like a robust data set to look at. So thank you.
Well, I'm going to take the prerogative of moving this along. Thank you very much, gentlemen.